composition, properties, mechanical and physical properties. So we have started the this classification of composite. Right? Classification, we have completed the uh, classification of composite based on the filler particle size. Then, according to filler particle size, we have classified the composite into megafield, macrofield, minifield, minifield, microfield, and nanofield. Right. So, macrofield, the particle size is and filler particle size is 100 to 10 to 100 micrometers. Minifield particle size is 1 to 10 micrometers. So in minifield there is zero point 0.1 to 1 micrometer. In microfield it is 0.01 to zero point 0.1 micrometer, and in nanofield it is 0.005 to 0.01 micrometers. Right. So here again this composite can be classified according to the filler additions. Uh, in case it may be a hybrid one, or a heterogeneous one, or fibrous reinforced particles. So in hybrids, there is a combination of two sides of filler, particle sizes of filler. Like it may be a midfield, minifield, it may be a microfield, minifield. So if suppose there is a combination of macrofield and midfield, right? So you have to write down this midfield hybrid. And if it is a combination of midfield and minifield, then you have to write the minifield hybrid minifield. So you have to write the particle which is having the higher diameter. यहाँ पे क्या है मिडीफिल और मिडीफिल इसमें सॉरी मैक्रोफिल और मिडीफिल में मिडीफिल की पार्टिकल साइज कम है. So you have to write down this like hybrid midfield, and if you add this midfield and minifield, then again you have to write down it as a hybrid midfield. So here also it is again classified into heterogeneous or homogeneous. Means sometimes what happens, we are same particle means अगर आप मिडिफिल के ही दो अलग अलग पार्टिकल्स से मिक्स कर रहे हो तो दैट इज होमोजीनियस. Or heterogeneous means you have to add two different midfield into minifield or minifield into macrofield. Then again it start with the handling characteristics. Means the viscosity of the depending upon the viscosity of the composite, composite can be classified as a flowable composite, like packable composite. Right. Again, core build-up composite and composite resin cements. So flowable composites means there are less filler particles present. Uh, so it is having the higher polymerization, less polymerization. While packable composite, they contain more number of filler particles, and its strength is more compared to flowable composite. So it is used in a posterior composites. Next one is core buildup composite. After, you know that after root canal treatment, we already prepared a cavity. We have to fill that cavity, right? So we have to prepare a core of a crown. So in that we use a core buildup composite, and composite resin cements like compomer, onmomer, zircomers are there. Yeah. Here we can see the composite types and its clinical indications. So in microfield composite, uh, where we can use microfield composites in enamel replacement in a class 3, class 4, and class 5 restoration, minimal correction of the tooth form, and localized discoloration. So where the minute we have to correct the minute defects in the tooth. At that time you can use the microfield composites. In hybrid composite is having maximum strength, so that's why they are used in posterior resin based composite restoration. Right? We all know that in posterior tooth there is a maximum masticative force is there, so we need a cement which is having the maximum compressive strength. So hybrid composite is having the maximum compressive strength. So they are used in posterior resin based composite restoration. Also in class 5 restoration. In class 5 restoration, what happens? Maximum flexural stress is present in a class 5 restoration. Right? So, to overcome that, we need to fill this restoration with the hybrid composites. And dentin build-up in a class 3 and class 4 restoration. This dentin build-up we will see when we see a case report at the end of this lecture. Then comes the microhybrids. Microhybrids are generally used in posterior and anterior direct composite restoration weakness, correction of tooth form and discoloration. So here microhybrids, the filler particles are so small. So the advantage of this composite is its better finishability. Right. So it can be we can finish it very nicely. There may be a very less surface roughness, so there will be less discoloration presence. Then packable composite, it is again used for this posterior resin based composite. Flowable composite, it is generally used for as a pit and fissure sealant, right? Where minute pit and fissure, deep pit and fissure are present when at their at these cavities, we don't prepare a cavity, we just fill this pit and fissures. Right? Again, liners in the class 1, class 2, and class 3 restorations. We will see further when we see the clinical case that flowable composite, when we applied it as a liner, it reduces the polymerization shrinkage. Then, depending upon the modes of polymerization, composite can be classified as follows: self-curing composite, ultraviolet light, UV light pure composite, visible light pure composite, dual core composite. Right. So, self-curing composite means they are chemically cured. When you mix two composite together, when the chemical polymerization reaction starts and it gets self-cured. So there is no need of external heat source or ultraviolet light source. But the disadvantage of this is minimum working time. Right? When you start mixing these two composite, it start curing. Yeah. So the chemical reaction starts. So you, you can't control the working. If you want more working times, and for proper molding of the composite and the finishing of the composite, we need a more working time. So then they develop the ultraviolet light curings and visible light cures. So, and the last one is dual cure. Dual cure means the polymerization takes place by two methods, like chemical polymerization and light activated polymerization. Both composites are there. Both methods of polymerizations are there. These dual cure resins, where we use these dual cure resins, when we have to cement a post or cement a crown, at that time we can use this dual cure resin. Different light curing units are there: quartz halogen lamps, plasma arc lamps, LED lamp, laser curing units. You can see this in this image. There are different tips for the plasma arc, again the curing light. Right. So, uh, the ideal method for using the curing light is a proper way of holding the curing light. The light should be parallel to the restoration, and it should be close to. That is, it is generally 1 to 1.5 mm close to the restoration. If you अगर आप इसको थोड़ा सा दूर रखोगे क्यूरिंग लाइट को, तो डेप्थ ऑफ क्योर बहुत कम हो. आप यहाँ पे देख सकते हो कि यहाँ पे उन्होंने थोड़ा डिस्टेंस बढ़ाया है क्यूरिंग लाइट. The curing light is kept away from the restoration. So here the depth of cure is minimum, right? Suppose this is the restoration and this is the composite increment we placed. If we place the curing light near to the restoration, then the depth of the cure will be more. Again, here in polymerization case, we have seen that if you apply this composition increment layer, like first section is placing a 1 mm composite, then again second section placing in another direction, third section in another direction, fourth section in this direction, fifth and sixth. So there is minimum stress developed in this restoration, right? Again, we can reduce the further stress by applying the flowable composite. Right. The number one here you can see it is a flowable composite layer. So due to the this flowable composite layer, there is less polymerization shrinkage and less destruction of marginal adaptation. Right. Then after placing the first increment of flowable composite, then you can add this above layers on by packable components like second, third, fourth, fifth, and sixth, and more. And ninth and tenth are again they are tooth colored, means enamel shade you can use for this topical layer applications. So again here we can see the different parts of the curing line. Right. This is pipe emitting light emitting pipe. The light guard is here. Then filter is here. Then actually this is a reflector and this is a cooling fan. Light source and this is a light source. This is a reflector. Light is emitted from this light source and it get reflected from this, and the normal light contains many wavelength, but what we need is a blue color wavelength, right? 460 nanometer wavelength, right? So these filters, what they do, they filter the light and allow only blue color light to pass through this, right? And this is the trigger. So here we are going to see the clinical applications of the composite restoration. Suppose this is the fractured tooth as anterior one. So here you can see the patient is having the history of trauma. There is a fracture of anterior crust. Cla- it is a class 4 fracture. Okay, that is the blockage of cavities on the incisor edge. Sorry, cavities on the anterior involving the incisor edge. So here we have to place a composite. So first and foremost step is you have to do the scaling and polishing of this adjacent tooth and the current tooth. Right? Why we have to do the scaling and polishing? To select the shade. First, we have to select the shade. So before selecting the shade, we have to do proper cleaning and polishing of the adjacent tooth, and we have to select the shade in a daylight, right? In a normal light, if you use a chair light, there may be alteration in the color. So you have to select the shade in normal light and select, suppose this is the V1 shade, right? So next one is preparation of the tooth. You cannot directly place the composite on the tooth and directly start filling with the composite. So here you have to give a proper bevel. I hope you can appreciate the bevel in this tooth. You have to first do the bevel. Uh, so, what is the clinical significance of this bevel? If you don't place the bevel, so there in the final restoration, you can see a line of demarcation, black line of demarcation in the anterior region. Right? So, while doing the beveling of the tooth, you can avoid this black lines. Then the second step is apply the etchant for 20 seconds. So generally most used is 37% phosphoric acid. Previously they used ascorbic acid, citric acid, malic acid, but the depth of penetration is more with this phosphoric 37% phosphoric acids. Again, your etching time should be 20 to 30 seconds. What happens if you etch for a less time, like you just apply the agent for the 10 minutes, and then again you start wash it, right? So there is a formation of calcium monohydrate. It is a chelate which is very difficult to remove by water swings. Right. So you have always you keep in your mind that you have to etch this enamel surface for more than 20 seconds, 20 to 30 seconds. Then you have to wash the agent with the water and dry with the three-way syringe. Step 4 is application of bonding agent and curing for 20 seconds. So here you have to apply the bonding agent by using the applicator tip. There are different sizes of micro brushes are there. Uh, you have to rub this bonding agent. What is the clinical significance of this bonding agent? It act as adhesive for the tooth and the composite. Right. What does the agent do? It causes the this erosion of enamel. There is a formation of micropores on the surface of enamels, and these micropores help to form the resin tracks into the uh, composite resin distribution. Right. Here again you have to boil, cure it for the 20 seconds. Then you have to place the composite. So the first you have to place the matrix. Right. Here you can appreciate we have placed the matrix on the both side of the tooth. So after placing the matrix, you have to place the composite into the increments. Different increments are placed here. First, horizontal increments. Then second is body of the body of the dentin we have to prepare. So layer by layer addition of composite is done. Then comes the final restoration before finishing and polishing. So you have to properly counter this counter the composite. Here you have to keep in mind that you have to maintain the golden proportion. So what is golden proportion? Actually, the width of the incisor. There is a ratio of width of the incisor to the lateral incisor. That is, it should be 1.6 millimeter, and from incisor to canine, it is a zero point 0.6 millimeter, and width of the canine to the central incisor, it is 1 millimeter. That is called as a golden proportion. So for doing the anterior composite restoration, you have to first visualize what should be your width of the tooth. Right. So suppose if there is a large gingival embrasure is present or the spacing is present, then you have to adjust your the incisor lines, like the proximal lines, mesial and distal lines. You have to adjust according to that. So you can appreciate this final restoration after finishing and polishing. Right. Again, we have to consider about the what we will say. We'll just revise it in quick session so that you can understand it better. So we'll just see the index. Basically, composite it is nothing but the a compound of two or more distinctly different materials with properties that are superior to those of individual constituents. And this is the definition. Then again, the composition it contains the resin matrix, filler, coupling agent, coloring agent, activator, and initiator. Right. So then again, filler can be we can classify the filler into silica and glasses. Then coupling agent is organosilane. Then coloring agent, mostly coloring agents are the metal oxides. Then activator and initiators are there. So the difference between we have seen the difference between the chemical cured and light cured. Then in physical properties we have compared the properties of conventional and microfield and hybrid composites. Then again, the physical properties, polymerization, shrinkage, water absorption, mechanical properties like surface roughness, modulus of elasticity, flexural strength, compressive strength, weakness, hardness. Right. Then classification according to filler size, methods of filler addition, handling characteristics, method of proliferation. Here there are some other classifications are there that is, according to use it is classified as anterior and posterior composite. Anterior composite they are mostly nanofilled composites, right? So what is the difference between nanofilled and other composites? That the filler size is very small. As the filler size is small, we can do a proper finishing and polishing over to the anterior restoration. Right? So anterior restoration there needs to be a smaller filler size. But in case of packable composite, like in a posterior composite, the filler size should be larger or it should have a maximum. Again, the particle size, filler size is megafield, macrofield, millifield, minifield, and nanofields. So all these are regarding this composite. This is about the method of polymerization, self-cure, ultraviolet cure, visible light cure, direct cure. So here I have mentioned one. This is anterior case, right? But if you want to place the composite in posterior, like in a class 2 cavity, right? So first you have to prepare a cavity. What is the basic advantage of this composite is they, you don't need to prepare a convention form, retention form, resistance form for this class to carry, right? Just you have to excavate the caries, then remove the unsupported enamel, and then start the basic principle of the composite restoration, that is etching, bonding, and application of composites. In some cases, what happens if suppose caries are very close to the pulp tissue, right? So we can not directly place the composite on such cavities. Why? There is a, as you know, there is a polymerization shrinkage in the composite. So due to that polymerization shrinkage, patient may face the post-operative sensitivity. The major drawback of the composite restoration is a post-operative sensitivity. So what we have to do, if suppose you can see your cavity is very deep, it is very near to the pulp. So at that time you can place a GIC, a base, and over that you can place the composite. Right? This is called the sandwich technique. Again, in sandwich technique, they are classified it into two types, that is open sandwich technique and closed sandwich technique. In open sandwich technique, what happens? In the proximal box at the gingival floor, they place the glass anniversary. That is the open sandwich technique. But the major disadvantage of this open sandwich technique is over a period of time, all you know that JSC solubility is very less. Sorry, JSC is highly soluble in oral cavity, right? So over a period of time, there is dissolution of glass ionomer cement takes place, and due to this glass ionomer cement, there may be a food lodgement, and there is a formation of secondary caries can take place. So they again developed the closed sandwich technique. Here what they do, they just apply the glass ionomer cement on the pulpal floor, then again on the axial wall, but they don't cover the GIC with the gingival sheet, like what we do in a class 2 base. Right? Where we apply the composing, where we apply base on the axial floor and pulpal floor, not on the gingival sheet. So what is the difference in amalgam restoration and composite restoration? Class 2 amalgam restoration and class 2 composite restoration. In amalgam restoration, we have to give a level, primary level, secondary level, occlusal conversions. Also, the line angle and point angle should be rounded. But here, we just don't need to give that conversion form or beveling. But sometimes in composite, we do need to give a bevel to remove the unsupported element. Like in this case, we in this case, in anterior case, you can see here there is unsupported enamel. So here, after the set selection, we have removed that unsupported enamel. We have given a proper bevel. So, so to remove the unsupported enamel, sometimes you need to give a bevel in the plastic materials. All this is regarding the composite restoration. In the next lecture, we will talk about the cast metal restoration.